that working?
Can you hear me? Oh, a little delayed effect. My name is Michael. I'm a speech therapist, and I've got, let's do some housekeeping stuff first. One, I'm going to put this disclaimer out. When I went to school years ago to be a speech pathologist, I really wasn't looking at a career in speech. I stuttered, and I just wanted to figure out what the hell was wrong with me and fix it. So then I ended up tripping in the rest of this. And so if I stutter throughout or stutter once in a while, I know what I'm talking about. I just trip up a little bit, all right? So just be patient with me. All righty. Let me learn how to do this thing here. John taught me. Whoop. There we go. All right. Look at those two people. That's Willard and Carolyn, my mom and dad. This was their 50th wedding anniversary. This was a year ago. This was 10 years ago. So this is coming up on the 60th anniversary this November. Now, the reason I put this up here is not to brag about my mom and dad and how much they like to eat, as you can tell, and swallowing. But basically to let you know I've got a horse in this race. I'm not just a therapist that's been doing this for years, and I can tell you because I'm the professional. But my dad took care of my mother because of health reasons. And then my dad had heart surgery about 4 years ago, that didn't go so well. So we ended up with a lot of dementia and some multi-infarct dementia. And mom takes care of dad now, and then mom's starting to show signs of some dementia. So I'm raising parents too. And it's not easy. All right, as we look at this picture, why do we eat? We need nutrition to stay alive. What else? Enjoyment is the biggest thing. We need nutrition. We need hydration. You know, if you don't drink, we're going to get dehydrated. If you don't drink, you get dehydrated. You get UTIs. You get stuff like that. Nutrition, we just don't develop. We just don't have the energy if we don't eat. But the biggest thing is we enjoy it socially. Everything we do, meetings, church meetings, business meetings, get-togethers, what do? We eat. Sometimes a little bit too much. And we drink a little bit, but we're talking about nutrition and swallowing issues. We're not talking about alcohol beverage. But sometimes the biggest thing with the point I want to make is a lot of these patients we're going to talk about, we're going to talk about certain foods, meaning eventually sometimes people is going to need pureed food or food that doesn't look that appetizing. The point I want to get across is we eat for enjoyment. So even if we have to have someone on the parade, let's by gosh make sure it's pleasurable, even if it's a parade meal. That's something we always forget. We got to remember, we got to keep it pleasurable. So that's the reason I threw that in there. All right, we are there. Well, let's talk about the general anatomy and physiology of swallowing. Now, I know we got some professionals here, so don't crawl on me. We're going to keep this in layman's terms. And Jill's sitting there smiling at me. We're going to keep this in general layman's terms, all right? Basically, we got our lips. We got our tongue. We have our teeth. We have the base of the tongue here. We have what we call our little epiglottis, that little thing that flips down when we swallow. It's right about here. We swallow, it closes, protects the airway, basically. We're going to come back and talk a whole lot more. I just want to give you anatomy right now. We have the vocal cords here. We have our upper esophageal sphincter. We have the back of our throat. We have our nasal cavity. We don't really talk about swallowing or that, but sometimes that comes into play when it goes down the wrong way or someone tells a joke while you're drinking milk. Now, what I want you to pay attention to, because we're going to do another slide, is right this area right here. A little place I call the valleculi, or we call it the valleculi. We got a little place right here. You can't see it, but it's called the piriform sinus. We're going to talk about that in a minute. I want you to really think about it or pay attention to it. Here we are. This is the front. Your nose is right here, okay? You're facing that way. This is your epiglottis. This right here is the valleculi. This right here is your vocal cords. These right here are the piriform sinuses. You have two of them. Places I want to talk about is right here, the valleculi and the piriform sinuses. We're going to talk about that later. It's going to make a lot of sense later, but I just want you to remember These two little areas, when I talk about things are pooling, things are pocketing, that's the area we're talking about. Just want to, because it's going to come in later and someone's going to go, what's the valleculi and piriforms? That's where they are. Basically, to let you know, these little areas can pocket and stuff can collect in them. When you eat Doritos, when you take a pill and you feel it sticking, that's where they're sticking usually. Am I right, Joe? Am I on the right track? Okay. Yeah, Joe. Keeping me straight. All right, let's talk about the different phases. The first phase is what we call, we have three phases, the pharyngeal, oral, pharyngeal, and the esophageal phase of the swallow. The first one, and we're going to talk about a normal swallow. So basically, put food in our mouth, we're going to enjoy it. This is the enjoyment part. We're going to chew it. We're going to put it in, our lips take it off the spoon, or our lips, we control it as we put it in our mouth, but the food, we take a bite, we start chewing. I watched people today at lunch and saw how much they were enjoying their food. Some was chewing with their mouths open, some were chewing with their mouths closed, some were wiping their mouth when they were done. But they didn't realize the complex action of what they were doing. Your tongue is moving side to side, you're chewing, and after you chew on one side, your tongue grabs it, throws it to the other side, it goes back and forth until it finally makes what we call a bolus. And that's your oral phase right there. You chew it to a point where you're getting ready to swallow, and it's right there, and we're still in the oral phase. We haven't hit the swallow reflex yet. When your tongue starts right about here to push, all of a sudden you trigger what we call the swallow reflex. And that's our pharyngeal phase. So the bolus comes down here. Your soft palate comes up and protects your nasal cavity. And if you notice right here, for like a 1 second, you quit breathing. Chew, chew, chew. You not quit breathing, but you stop. You're no longer taking in air. And that can be a problem for people on oxygen, wanting a lot of air. All right, so the epiglottis closes. Soft palate closes, protects the nasal. Your epiglottis, it closes and protects your airway. So right here, your airway is open. The food is coming down, the airway closes, the epiglottis closes, protects the airway, and channels the food to the third phase, which is the esophageal phase. Your upper esophageal sphincter, epiglottis closes, upper esophageal sphincter opens, and the food goes that quick. And it happens that quick. So that's the normal swallow. Any questions about a normal swallow so far? All right, let's talk about an abnormal swallow. Things that happen when things aren't working right. The oral phase. We talked about the lips a while ago. All right? How about someone, and we're talking about dementia patients, but we're all talking about patients who may already had a stroke before they even got the dementia. So there could be a lot of things going on with just the mouth itself. John, this thing's killing me. Okay. Spillage, droolage. What happens a lot of times when patients, you're sitting there with them, they don't have a lot of sensation anymore. They can't feel spit. In other words, it's right there, it collects, and after a while it comes out. They'll feel it and they'll wipe. They'll wipe all day, but they won't initiate a swallow. So a lot of the sensation's gone that they can feel inside their mouth, but when it starts pouring out, and some may wipe, some may not. You have to cue them. Another thing that can go wrong or a problem is holding food. You put food in someone's mouth, and you're thinking they're chewing, they're holding it, you go put another bite in, and the food is still sitting there. It's just sitting. And they're making no effort to chew or swallow it. Another problem with the oral phase could be chewing excessively and not even starting to swallow, meaning they put food in their mouth, or you are helping them put food, and they chew and chew and chew and chew. Now, some of these could be from just the phase they're going through with their dementia, or it could be teeth. If they're missing a lot of teeth, they're chewing and chewing and chewing, and there's so many spaces that nothing is there to chew. And they can excessively chew for a long time and really not even start the swallow process. Then there's also pocketing. This happens a lot when you have the patients with a history of the strokes. If they've already got some weakness here and they've had a stroke, they got weakness, but they controlled it. But as dementia progresses, a lot of times they don't have that, again, control, and the food can pocket. Yes, ma'am?
I had bulbar polio, which the bulbar polio affects your swallowing.
Yes, ma'am?
And I had a lot of difficulty swallowing, so I don't know if I'm pocketing food or what. Do you?
Tell you what, when we get through, I'll talk to you. I'll be glad to.
Okay.
All righty? Let's see, so pocketing. The next one, let's talk about the pharyngeal phase. All right, we talked about a while ago is when you initiate your swallow, things that can go wrong with the pharyngeal phase is premature spillage of food or liquids, which means, I brought George. I don't have to go back to the other one. I called him George until about 2 weeks ago. A student says, no, his name is Tom. It says it at the bottom. I didn't realize that. Right here, here's your epiglottis. Can y'all see this pretty good? Stop. You should have got closer. The pharyngeal phase, when you initiate a swallow, this little epiglottis closes and protects airway. So what we call premature spillage is as you chew and chew and chew, the food starts going down the base of the tongue and collects in that, remember the area I called the valleculi? It starts collecting. So basically, here's your tongue, here's your epiglottis, they chew and chew and chew and chew, and premature spillage, and it starts going down. Me and you, we would have chewed, initiated a swallow, it's gone. They chew and chew and chew, and the food starts collecting and hanging right there, but they haven't started to swallow yet. So that's the premature spillage. The delayed swallow, again, is part of the premature spillage. You have not started to swallow yet. Me and you, we chew, we have the bolus, boom, we get it going. Them, it's pouring back, and before they initiated the swallow, it's already pouring back, and when they finally initiate one, the delayed, the food is already going down before they ever trigger the swallow, meaning protecting the airway. So all that isn't working the way it should. And we'll talk about the results of that in a second. Pharyngeal residue. I mentioned a while ago, remember these places. The valleculi, which is right there where your epiglottis is, and on either side of your airway we had what we call the piriform sinuses. They're little pocket areas. We all have them. In fact, I think it's by nature they're there to protect us because a lot of times they're like reservoirs. They catch the overflow. But sometimes they can get overflow too much. It's like a dike. They spill over the dike into the airway, but they actually are there to help us. But after the swallow, let's say someone swallows some food or liquids, and after they swallow it, stuff is still hanging around. People can aspirate what's still hanging around because when you take another bite, they have nowhere to fall into. The residue, it's already full. The valleculi or the piriforms are full, and there's nowhere for the food to go, and it can spill into the airway. So all of these episodes can result in what we call aspiration or penetration. I didn't make a slide. I was in a hurry. I was only given a few days to do this presentation, so I forgot to put the esophageal phase, abnormal. Now, it really doesn't have to do with dementia with the esophageal phase. This is more physiological problems that can happen to anyone. The dementia really doesn't have to do with this, but something you want to be aware of. With the esophageal phase, the upper esophageal sphincter, when it opens, food goes into the esophagus. And it's a peristalsis movement. The normal swallow for esophagus is a peristalsis movement. What can happen to some people, just their age, history of some problems with their esophagus, but they can have slow motility, meaning food can go down to a certain point and stop. They can have a stricture to the point of the food goes to a certain point and the food is only allowing it to go so much and then it starts backing up on them. What can happen with this? Not choking. They're full. You get a patient who has dementia, they can't really talk to you or explain to you what's going on, but if you've noticed after so many meals, after 5 or 6 bites, they go, I'm full. And you're thinking, you're not full. Yeah, I'm full. They can't tell you they're full here. Not full in the stomach, they're full here. So they're only eating 4 or 5 bites, I'm full, and then you try to give them more. I told you I'm full. Well, they are. It's full right here. They can't take anymore. After a while, it finally goes down. You may have some of them that eat, and all of a sudden they regurgitate some. It's got nowhere to go. It's going down so slow. A lot of these patients, guarantee you, and Jill can agree with me, is, these patients, generation, their grandmothers and grandfathers and mom and dads taught them, you don't drink when you eat. You're going to fill up on liquids. So why? They don't drink. You need to alternate. You need to have some liquid in there and help that esophagus work. 9 out of 10 times, that's usually the problem with patients complaining. So you got to make sure, one, when you're feeding them, you get that hydration in there every 2 bites, because one, it helps the esophagus too. You're making sure they're staying hydrated. All right, so that's about the esophageal phase. Again, that's not a dementia thing. That's just a general body thing that you need to be aware of. All right, the effects of the abnormal swallow. Let's see. We talked about penetration, aspiration. I'll give you some definitions. Penetration is when your swallow is based on air pressure. So penetration is when, here's my hand again, here's your tongue, here's your epiglottis, and when you initiate a swallow, your epiglottis closes and protects the airway. Penetration is when the liquids or food wants to go into the airway, but they come back out. They come in and the air pressure is pulling them back out. And it could be flash penetration or it could be deep penetration. Deep penetration is when it's almost wanting to get to the vocal cords. They didn't aspirate, but they're penetrating. The problem with penetration is you do that enough and you get tired when you eat, you're eventually going to start aspirating. Now, the next one is aspiration. That results when food or liquids enter the airway and they go past the vocal cords. Okay, and so that's what we call aspiration. And when it goes past the vocal cords, where's it going to? The lungs. All right, and both penetration and aspiration can result, and again, that's reflex, not reflux. Someone else retyped this for me, so that's reflex, not reflux. But it can result in a cough, a throat clearing, or a cough, which is good. We want people to cough. Too many people will start coughing and they do this. Sorry, I got loud all of a sudden. But they start covering. A cough is a good thing. You want to cough. If it's going down the wrong way and you see your loved one doing this, no, let it out. They can be polite if they want, put their hand here. But tell them to cough, because your cough is a protective mechanism. Your body, the whole problem with the swallowing, not a problem, the procedure with swallowing is to protect the airway. Your epiglottis is the first stage. It protects the airway. Second one is your vocal cords. They close. If it gets past the epiglottis, you got the vocal cords. If it gets past that, it's the cough reflex. Everything's made to protect the lungs. So if they start coughing, cough, get it out. And once they start coughing, don't go, here, drink this. No, let them get the cough completely done, then give them something to drink. Because if you give them something to drink, what are they going to do? Well, if you're giving something to drink in the middle of that, you're just going to pour more in there. Get the coughing done, okay? Now, according to the patient, you may also not even have a cough. That's why I hear the most, well, they're fine, they don't cough. That's when you can have what we call silent penetration and silent aspiration. That's what a lot of people just don't realize it. Well, wouldn't I cough if it's going down wrong? There's nothing like giving someone something to drink and you're watching them and you're going, you're a silent aspirator, aren't you? Because you can just tell, you can see all the movements are moving so slow, and with their history of lung issues, you know they're silent aspirating. Okay, so that's, again, there's no cough reflex. They don't cough, they don't choke. All right. The effects of aspiration, no matter what the form, can lead to aspiration pneumonia. Your lungs are dark, moist, and warm. Perfect place to grow bacteria. If we got a glass of juice, milk, coffee, tea, turn off the lights, hit the 98 degrees, come back in 3 days, what do we got in all those glasses? Bacteria. It's just stuff growing all in it. It's just floating all there. That's what can happen to your lungs. Now, some patients, they can aspirate one day, they're a mess. They could die off that one day. Other people, I've seen them aspirate for the longest time, but eventually it's going to hit them. Eventually it's going to get them, because your lungs can only take it for so long. All right, what if my family member is having any kind of swallowing issues? Well, first of all, discuss it with their primary care physician. Doc, Mom, Dad's having a terrible time swallowing. Doc, I'm having a hard time swallowing, okay? And what they can do is they can refer you to a speech therapist that specializes in swallow. Am I jumping ahead? Okay, jumps ahead. They can refer you to a certified speech pathologist that works with swallowing disorders, okay? And they can do a bedside eval to watch your swallow and then to determine if you need what we call a modified barium swallow study, okay? Or the doctor just may want to go ahead and order one anyway. He doesn't have to wait for the speech therapist. What that is, a modified barium swallow study, it is performed under fluoroscopy under direction of a radiologist and with the assistance of a speech pathologist. Basically, it's a table, x-ray table, that is flat. You have the x-ray arm right here. What they do is they lift up the table, The arm's here, you're here, and they put you in a chair, and it's the easiest test in the world. All I do is, you're sitting here, the table's here, I give you something to eat. Helps us figure out what's going on. We give you a variety of things to drink and a variety of things to eat, and we watch it. Now, it's not a pass or fail test. It's basically to let us know, are you having trouble? And if you are, what can we do to try to help fix it or compensate for it? Here's what it looks like. Here's a person before they swallowed anything. Again, there's your epiglottis. Here's your airway. Your vocal cords are right about here. Here's your trach. And then you can't see your esophagus, but it's really going right through there. And you'll be able to see it when someone swallows. You can see it go right on down. What we do is we give you something to eat. We watch it go down. Here's an example. This someone has already swallowed something, as you see right here. That's your valleculi. I told you stuff that kind of wants to hang around. Here's your piriform sinuses. So they already had one bite to eat, something to drink, and it's still hanging around. Hadn't aspirated yet, but you still is hanging along the wall. Takes another swallow. This is a premature spillage. You see it pouring down, the epiglottis is still up. It hasn't even initiated yet. It's pouring around it, and it's pouring down into the piriforms, and then all of a sudden, what we got here? Going into the airway. That's the deep penetration. It hadn't gone past the vocal cord yet, but it's almost there. And then after they swallow, so what they did is it came back out, and again after the swallow, we still got a bunch of stuff hanging around. Now, you can aspirate before the swallow, during the swallow, or after the swallow. If you got a bunch of stuff hanging all in your throat, and you swallow one more time, you can aspirate that just as easy as you can aspirate on that first swallow, something going down. So that's why you may have a loved one who's sitting at home and you give them something to eat, and they chew, and they swallow, and they swallow, and they swallow. They can feel it, and they're trying their best to clear it on their own, which is a good thing. They're glad they're doing that, because some of them don't feel it. They have no sensation. The ones who silent aspirate, they don't, but the other ones, they can feel it, and you can ask them. Sometimes they can tell you, yeah, I feel it. Other ones, well, I don't know, but they're automatically, their bodies tell them, I got to re-swallow, okay? So that's, again, that lets us know what we can learn from it. All right, now let's go over some possibilities of, I did the modified. We're taking a look. First thing, let's talk about liquids. No problems. He did a flash penetration with thin liquids, but if we take really small sips, he's all right. If we can really judge how much they take, and what we want to do is make sure someone stays on regular food and liquids as much as possible. So their flash penetration or just a little bit of residue hanging around, but re-swallows, clears it. Let's keep them on a regular diet as much as possible in thin liquids. Something I forgot to add in here is instead of the next phase would be if they're having a little trouble and it's going down wrong, we usually do room temperature liquids. If there's a problem, I grab some ice and mix in the liquids with ice, then give it to them. Why would I do that?
You feel it more?
You can feel it more. If I came up behind you and put an ice cube on your back, what are you going to do? Reflex, okay? Same thing with your muscles. This won't happen to everyone. Again, you got some people, they won't respond to it, but a lot of them do. And it's funny to watch someone who deep penetrates or penetrates with warm liquids, but you give them ice cold, and that's a swallow, is just perfect swallow. So we try to do different techniques. We just don't go, not doing this, let's do this. No, let's try our best to keep them on thin liquids as much as possible. Now, if they're having, no matter what I do, and I want to talk about some other techniques in a minute, but no matter what I do, it doesn't work with the thin liquids, then we go to nectar thick liquids. The consistency of buttermilk is thicker, and the reason we use that is we talked a while ago about premature spillage and a delayed swallow. Well, if it's delayed and it's going back and it's water, gravity works. If I put this table on its side and grab a spoonful of water and a spoonful of nectar thick liquids and pour them, which one's going down the table the quickest? Water. Gravity works. Same thing in your throat. You take a sip, and before you initiate a swallow, that water's already gone, and half the time being aspirated down the wrong way. Nectar thick liquids just slows it down and allows the muscles enough time to react. That's all it does. Now, we have some patients that If nectar doesn't work, then we try honey. And we're not talking about honey itself. We're talking about honey thick liquids, the consistency of honey. I hate to say what town this was in because of all the trouble they're having, but I worked in a nursing home years ago in Bluntstown, about 20 years ago, and nursing facility, and I went to the kitchen. I said, I need some honey thick liquids, please. I came back and had a 12-ounce glass of Tupelo honey. Not only are we making sure she swallowed safely, but we're going to give her a diabetic coma too. So you gotta, but honey thick, that's our three consistencies: thin, nectar, and honey. All right, and there's our honey. Now, if the patient is able to follow directions, your loved one's able to follow directions, and the other techniques is, besides trying to ice, is head positions. If they can follow directions and then they can take cues, and if someone's with them, sometimes we can try head positions. One is tucking the chin, and another one is turning the head right or left. Again, you just can't walk into someone, they're coughing, and say, hey, tuck your chin, because sometimes tucking the chin can make it worse. But for some people, under video, we can sit there, have them take a drink, look down, swallow, and again, it forces, when you tuck your chin, it forces the larynx up, and it forces that epiglottis close, or the larynx lifts up, and it forces that epiglottis close, and we result in a good swallow. So the patient can, if they can follow directions and take the cues, thin liquids, tuck your chin, swallow. Other ones, if we notice they're pocketing in what we call those piriform sinuses, because a lot of times they take a swallow, it pours in the sinus, and then from the sinus pours into the airway. Well, a lot of times if we can get them to turn on the side that's collecting, basically you're closing off that pocket area and you're using the strong side to do the work. That can work. But again, we're working with dementia, so sometimes if they can follow directions, we try our best to make sure we keep them off the thick liquids. Because once you put them on thick liquids, you're worrying about hydration issues constantly. Because it's not the same as drinking water. It just never quenches the thirst. It's keeping them safe. So as much as we can keep them on thin liquids, the better. Okay? Any questions so far? I asked, but then I didn't look. Okay. All right, let's talk about food. We talked about liquids with a modified. Now let's talk about food. We checked their swallowing. They chewed, they swallowed. Everything went down fine. Regular diet. Let them eat. Okay? The second scenario could be what we call a mechanical soft diet. Now, mechanical soft diet is basically a regular diet. Food is vegetables are vegetables, bread's breads, but the thing is the meats. Meats are chopped up or ground up. Because again, we're looking at what? Usually the dentation. If they're missing teeth and you're trying to chew, or you get someone who fatigues easy, you just don't realize how much eating can wear a person out. Especially when they get so weak in the first place. And you give them a bite and they chew, and they're chewing and they're chewing. They're tired from eating after a while. Especially, as they chew and chew and chew, that can wear them out. So giving them ground meat or mechanical soft meat really helps that issue there, because you get a regular piece of meat, pork chop, chicken, and you cut it up and give it to them. They'll sit there and chew it for 5 minutes before they ever swallow. Not chewing it correctly, and it falls down the airway that we talked about a while ago, and it's hanging in one of those spots. Where are you looking at? You're looking at a possible choking episode, because they really couldn't chew that big chunk of meat. So we're not pureeing the meat, we're just chopping it up, okay? And the last one is a pureed diet. Pureed diet is, and please, if you ever have to do this, do not buy baby food. When people say, oh, and family members are the worst, you walk into a patient's room, you got them on pureed, you're building them up, you can eat this, and they go, yes, I can, this is delicious. And a family member walks in and goes, ew, you eating that? Guess what's going to happen? They go and push the plate away. Pureed food, whatever you eat, you should be able to puree it also. And there are ways to do that. Google, if you have issues and you need to find recipes, there's so many books online. There's so many recipes. You don't even have to buy a book. Just Google dysphagia recipes, dysphagia cookbooks. This is just one. This is from a local dietitian here. In fact, I got a couple pages written in there. I have no money monetary. I just got my name in there, so that was cool. But no, Google it. There's several on the market, but it gives you ideas that you can puree anything and make a delicious meal out of it. Again, the point of, even if they're on parade, make sure it's enjoyable. You got to make sure it's tasty. All right. Let's go back to again, at the very end, liquids and solids. If we tried everything we could and we watch, basically, our last determination is, there is a fail part. If everything is going down the airway. And that's the scariest thing when you're sitting there doing a swallow study and you can just see it all going in and you're hollering, cough, cough, cough. And there it goes, and it's not coming out. This is when we recommend NPO, nothing by mouth, because this is when they're aspirating basically everything. This places the patient at the very high risk of aspiration pneumonia. Again, those liquids I told you, the stuff gets in there, it starts rotting. You got aspiration pneumonia. And basically, for Alzheimer's patients, this is what basically is the end result for a lot of those patients, is aspiration is what gets them. Because they basically forget how to swallow. As they progress, the ability to swallow is gone. All right, can speech therapy help? Why, yes, we can. You didn't see that, Joe, did you? Yes, we can. All right, we can do a lot of things. Let's go back to the oral phase again, the mouth. Remember we talked about how you couldn't control it? A lot of exercises, simple little things you can do. If they can't follow directions, again, exercises, getting that mouth stronger, getting them more aware. Training the family. A lot of times, if the dementia is so progressed, a lot of times it's you're in charge. And it's the strategies that you use to make sure they're safe. And a lot of those could be small bites, small sips. Again, help the esophagus, but at the same time, small bites, small sips. Make sure they chew and swallow. Make sure don't give them another bite until they chew that one. A lot of times they may hold it. Like I said a while ago, they may hold it. It's funny how you can do simple things. She talked about music earlier today. People remember that. They sit there, they don't do anything, but you play music and all of a sudden they start doing it. I've noticed over the years, you've got to try different things. And one I've tried is 1, 2, 3. On a count of 3, because they swallow, and they sit there and you rub their throat. And then I go, on a count of 3, we need to swallow. 1, 2, and it goes. It doesn't happen every time, but you got to try anything you can. Small bites, small sips, straws or no straws. Sometimes straws are wonderful. Other times, they're your worst enemy. When you take liquids from a spoon, and sometimes you may need to feed your loved one with a spoon instead of a cup. Mouth can hold a lot, the throat can't. So a lot of times just doing it with a spoon, small sips from a cup, because you can control how much you get it. When you use a straw, what are you using? Your lungs. It's a vacuum, and if your reflex is moving so slow, you take a sip, it's already gone back into the airway, and they're coughing already. So be careful with straws. They can still use straws sometimes, and you just got to control it. Use your finger to pinch it. Encouraging swallows and re-swallows. Effortful swallows and re-swallows. Again, if you know from a modified swallow study it's hanging there, but if they swallow 1 or 2 more times, it can go down better, and they can follow directions, encourage them. Swallow 1 more time. Okay. Good. That's what I have to do with my dad. We go through a little process, that he's got to re-swallow from the swallow study. Even though he might not clear his throat, we know we got to do the extra swallow. All right, swallow 1 more time, 1 more bite. Okay, good. All right, let's take another one. If they can follow directions. But you've got to cue them. Self-awareness, your part. How's their voice sounding? Are they coughing? Are they clearing their throat? Because they may have a swallow study 2 years ago and everything's working great, but the more you feed them, you're starting to notice what? Or they start talking, you got a wet voice, a gurgly voice. So let's say you had a swallow study 2 years ago, everything's going great, when then now it sounds like we need another evaluation, we need to recheck. Because what worked, you remember, this is a progressive thing, so what worked in the front, in the beginning, you may have to play with it some more as you go. All right, another thing, just treatment-wise. There's a lot of therapies out there. I'm just going to mention one, E-stim. This is where they work with the patient. Again, if the patient can follow directions and can look at you and can pay attention, and a lot of dementia patients can do that. People don't give them credit. If they're high-level dementia, E-stim, it basically works on the muscles and see if you can, helps you try to retrain the muscles. Will it work on everyone? No. Is this a miracle cure? No. But there are some things that therapists can try to use to try to get them, if they're on thick liquids, try to get them off the thick liquids. All right, other things that we can do. Vision. Are they legally blind? Do they wear glasses? Are the glasses clean? I can't tell you how many times I leaned over someone and looked and, how in the world are you seeing with these things? Can they see? If they're legally blind too, and they can follow directions, put the food in certain groups and then do it like a clock. Hey, Dad, your meat's at 12 o'clock. This is at 6. This is at 3. Okay. Where's my meat? Oh, okay, right there. Think about just simple things we don't think about. A lot of times we get a plate, throw it, and here's your spoon, fork, have fun. If they've had a stroke before and they got the dementia, do they have the visual neglect? You're aware what visual neglect is for those who don't know. Sometimes when you have a stroke, not all strokes, but sometimes a patient can end up with what we call visual neglect, right or left. It's not the eye, left eye or the right eye, it's that visual field. And a lot of times, due to stroke, it's cut off. So they can see everything on this side, but they look down and they see all their food on this side, but they see nothing over here. So if they have a stroke in that history and now you added on the dementia, it's going to make even more challenged. So you've got to actually give them more help because they'll eat half this side of the plate and won't touch anything over here. So always make sure the glasses on that side that they can see. Hearing. Do they wear hearing aids? Do they work? Are their batteries good? Are their ears clear of wax? Does the loved one put the hearing aids in? My mother refuses to put my dad's hearing aids in. Says he can't hear, but she won't put them in. Now she's lost them. I'm just venting a little bit. Dentures, dentation, dentures, do they fit? If a patient has lost weight, guess what's the first thing that's going to be affected? Their teeth. They're not going to fit. If they lost any kind of weight, let's talk about the esophageal thing. It's 6 on them, you don't know why they're not eating, but after a couple of weeks they're losing weight, then it's just a domino effect. The teeth aren't fitting, they're going to cause sores in the mouth, so we need to make sure they fit. Do they need denture cream when they use them? Do they have their own teeth? If they do, and even with the dentures, hygiene. Make sure the mouth is clean. Brush those teeth. Why? Bacteria again, okay? Remember a while ago when I said drooling and it pours out? Well, you can have drooling and it can pour backwards. If you got a bunch of rotten teeth in there, that's going to have all the bacteria. And then when you're swallowing your saliva mixed with bacteria going into your airway, it doesn't have to be food or liquids. It can be spit full of bacteria getting into the lungs, and we got aspiration pneumonia just from spit. That make sense? All right, positioning. 90 degrees. Hope I don't mess this up. I'm getting old. We want them when you eat, if they're in bed or if they're sitting in a chair, we want them in 90 degrees. We want them up. Because the worst thing this leans back. Good. Last thing you want is for them to eat like this. Why? What do you see wrong? Gravity. Here, take something to drink. They got the head up, or a straw, or a cup. They can't control it. And again, gravity. Before you can control it, it's already going back. 2, I'm already breathing heavy. Can you hear it? If they got a cough, what's going to happen? They can't. What do you use when you cough? Your abdominal muscles. You can't, if there's something goes down the wrong way, they can't get it up. Here, they can. So positioning, in bed or in a chair, you got to make sure you get them up. Before they ever, if your loved one's in a nursing home, you make sure the staff knows, get them up. And preach to it till you're blue in the face and never stop. Let's see. Consciousness. Please don't put food in someone's mouth when they're asleep or lethargic or sleepy. Mom, you hungry? You want to eat? Yeah. Well, I don't think you need. Oh, she's hungry. She can eat. No, do not put anything in that mouth if they're asleep or lethargic, because you're just asking for a choking episode, asking for aspiration episode. That quick. You don't feed them while they're asleep or acting like they're asleep. Taste buds. They don't eat like they used to. Things don't taste like they used to. Memories aren't there. Things that, oh, Mom loves this. God, Mom loved this dish. Mom's not touching that dish because Mom doesn't remember. Also, things don't taste the same. But for a lot of people, sweet things still, the taste buds react to sweet things a whole lot better than regular food. So when you have to help someone eat, have a little thing of pudding or something on the side that, a lot of times you put that fork or knife and they're going, But if you dab it in some pudding and they taste that, you'll be amazed. That mouth opens up that quick and they start eating. So it's just tricks you got to learn, but just remember, taste buds. Say, why don't they eat? Well, I have to admit, you get a lot of people go, well, it's just this food at this facility. No, it's just terrible. Mom won't eat it. Well, they bring something from home, and guess what? They don't eat the food from home either. There's things you got to do to help them, trick them into eating if you can. Finger foods. With the dementias, they really don't pay attention to forks anymore. And they may start reaching toward the plate and just grabbing it with their hands. If that's the case, and they can eat some regular foods or soft foods, the fine deli meat, you can roll it up. You got the fish sticks, you got the vegetable sticks, finger foods. Because a lot of times they forget how to use a fork, but they will get their hands, so get finger foods. A lot of times you're going to have to help them for a lot of patients. Forget about the clock. Forget about you're in a hurry. You got to go slow. You got to take your time. Small bites, small sips. When I first started years ago and we outlawed this, I walked into a patient's room and this CNA, there was a pureed plate and she had the milk and she grabbed everything and put it in the cup, poured the milk, stirred it, got a syringe, leaned over, and the poor patient was going, and I'm sitting there and all, because I'm a fresh grad, going, take your time, spoon at a time. Even the liquids, if you have to, use a separate spoon, just take your time. You can't rush them. Okay? All right, if NPO is recommended, what then? If I walk to you and say we did the swallow study, your mom, dad, they're aspirating everything they're eating. That's when, we had that earlier class today. If some of you attended, it was the, what was the name of it? You were there. End of life issues. Okay, I'm sorry, I'm word finding. My Alzheimer's. End of life issues is there a living will? What are their wishes? Okay. Your options. You're looking at, let's say he failed the swallow study. We don't want a peg. No peg at all. Well, that's fine. I'm not there to push a peg, but I am there to push safe feeding. So, one option can be let them eat. Let them keep eating. They've got a living will. They do not want any special tube or anything. So guess what? We got to make sure they're eating as safe as possible. Just because they aspirate and go, no, we still need to make it safe. So there are some things you can still do to make it safe. Again, small bites, small sips, making sure they're up, doing everything you can. Now, if they're aspirating everything, I go to water. Not just pure water. I mean, they got food, but liquid-wise. I don't want to if they're aspirating honey thick liquids, I don't want to give them honey thick liquids. They're going to aspirate it. So let's be the safest. Remember that little table I showed a while ago that when I said milk, juice, coffee, tea, milk, we put it here and for 3 days, and what's it going to look like? Let's throw in some water in there, the 3 days. Every one of them is going to have a lot of junk in it. What about that water? It's going to be like a dog dish, I like to describe it. It's not going to have a bunch of stuff growing on it, but it's going to be slimy around the side. But of all those things, what is the safest? Water. We're something 60% water. If we aspirate some water, our lungs usually can try to handle it. It can handle that a whole lot better than anything else. So if you're in a position where your loved one is aspirating everything, but you don't want a tube, stick with water. Small sips of water. That's a whole lot better than anything else. Don't let her have milk. No. You want to stick with stuff that won't grow bacteria as much as everything else. The next one is a combination of non-oral feeding, meaning, yes, we will get a tube, but there's no way she can eat enough or he can eat enough to keep them sustained. But let's let them have some pleasure too. So if they can't eat or drink a few things, let them, but the tube is the main primary nutrition, but we're also letting them play a little bit with some food, just for pleasure. Again, let it be enjoyable. Palliative care, meaning we're not going to do anything. They're on hospice. Let them have what they want. Okay? They deserve it. Like my dad says, I'm 82 years old. If I'm going to sleep all day, I'm going to sleep all day. Which I don't like that, but... And a last one is artificial nutrition, and that is what we call the PEG tube. They go in, they put a PEG, and tube fed the whole time, and it's the family's choice, not ours. We're just here to recommend it. Okay? And let me throw something in there. That's not always going to protect them either, because you can still aspirate from PEGs. Now, why is that? We're not putting it in the mouth. Reflux. The food when they're sleeping, or sometimes a lot of people, it can just come right up on them, and they can aspirate that too, and so we can end up with reflux from a PEG tube. So a lot of times when you think, well, they're aspirating everything, let's do a PEG. Well, PEG can cause problems too. So just be aware of that. All right. Whew. I'm doing good. Any questions? I did that good?
I'm curious. I have somebody that had Alzheimer, whatever the thing,
Yeah.
and eventually, like, his jaw got locked up. Is there anything you can do, like, if you start noticing, like, jaw getting locked up or something?
Now, is it locked up, or is it just him just to put food in and he holds?
No, he was locked.
Okay.
Like, I mean, for a while, he couldn't eat, well, you kind of see it gradually, like, the eating process was decreasing, but usually we just, like, he couldn't open or release his jaw like a normal person.
Okay, and did that happen? Could he talk? Could he say things? Okay, so it was just always kind of locked up. Well, then that's already in the place. A lot of times we can do, sometimes we don't even need to do a modified. We sit there and do a bedside eval, and we can watch and see there's not much we can do here. And sometimes that's when they're under the doctor's care. Is there any kind of medication that could be causing that? A lot of times everyone thinks it's the dementia or something, but it's a whole body thing. Sometimes the medication could be a side effect that's causing that. It could be the disease process itself. To me, that sounds more other than Alzheimer's. That sounds like something else going on too. Yeah, and so it's a combination. But a lot of times if they're like that, or is he able to follow directions? Is he able, and that's where you're jumping way ahead from one thing already to the, what are we going to do? Yeah, that's where you're jumping into, because he can't get nutrition, he can't swallow it, open his mouth, then you're looking at what's his wishes. Okay. Anybody else?
We're in the period right now of doing thicket with everything, water, juices, food. Is there anything else out there?
You know what? There is. Because thicket tastes terrible in water. It tastes nasty. Anyone ever drink thick liquids before? That's a brave young man. Someone, the speech therapist, made you drink them, didn't they?
My teacher.
There you go. What it is thicket is made out of modified food starch, which is what's food starch. It thickens when we cook it, right? Great for gravies. Well, modified means it thickens when it's either hot or cold liquids, which is great. Now, it's great in coffee. It can be great in some milks and the juices. Never put it in a carbonated drink. You got a science experiment real quick. It just starts boiling over, and then it just tastes like a 5-day-old Coke anyway. Nestle has a product, there's called Thicken Up, and then there's Thicken Up Clear. It's more of a gum substance, and you mix that. The first one is Thicken Up by Nestle, and that's modified food starch, okay? But they made one now called Thicken Up Clear. Now, some of the pharmacies have it, or you can get online, look up Nestle swallowing disorders, and look up for Thicken Up Clear. I've had patients that I mix that, but you get the water's ice cold first, then take the ice out, because if you don't, you mix it and let it sit. It looks like water, it's not cloudy, and it tastes like water. I mean, I mix it and have my patients practice, and they get it and they chug it because it looks and tastes like water. So that's if you're having trouble with that, that's what I would recommend. Anything else? Let me put something up here real quick. Dang. I need one that works. There we go. I said a while ago, if you needed a referral for outpatient speech therapy, your doctor can help you, or TMH. This is their number to TMH's outpatient therapy. Just tell them if you're looking for speech therapy, swallowing service, or anything speech therapy. That's the number for the speech therapy. And 2, let me put, if you got any questions that I can help you with, again, if it's an emergency, call 911, not me. But if you got any questions on swallowing, that's an app. RUDD, TMH.org. That's my email. If I can help you anyway, let me know. I'll do my best to help you. Any suggestions I can do, I'll lead you in the right directions.